Welcome to Doc Discussions with Dr. Jason Edwards, brought to you by St. Luke's, St. Louis.
Hello, this is Jason Edwards, and this is Doc Discussions. I'm here today with Dr. Nimrod Barashi. How you doing, sir?
Good, thank you. How are you?
I'm doing well, thank you. So you're a urologist.
Yes, I'm a urologist. I graduated from urology last year at WashU and came to St. Luke's in September.
Yeah, very good. Now tell us about your background. Where are you from originally?
So I was born and raised in Venezuela in South America, in Caracas. And then my parents are actually Israeli, but they came to Caracas in the late 80s. And I grew up there, and then I went to medical school in Bogota in Colombia.
Sure.
Did 6 years of medical school like most people outside the U.S. do. And in 2016, I came to the U.S. I went to the University of Chicago, did a couple of years of urology research. And then I started my residency training. I did a year of general surgery in Chicago as well at the UIC. And then I came to WashU in 2019.
That's great. And so, when people think of Colombia, you think of like this Bogota, this rough town. But my brother-in-law went a few years back to play golf there, and he said it was a very nice city.
Absolutely. I mean, at least the years I was there, Bogota was phenomenal. I mean, it was a beautiful city, lots of things to do. It was safe. I really liked it. I mean, there was probably some of the best years of my life.
Yeah. I've heard it's a nice place. It's a very hilly city too, right?
Yeah, it's 2,600 meters above the sea level. So It's a very, very high. It's almost like Vail in Colorado.
Wow.
So very, very high altitude, some rain, but very hilly, very nice. And Colombia in general and Venezuela, both beautiful countries. They have everything. You have, sea, desert, forest,
waterfalls,
whatever you want. Yes.
Is Angel Falls in
Venezuela?
Venezuela? Yeah. That's great, man.
Waterfall in the world. Yeah.
Yeah. Very cool.
Yeah.
And so it's not easy. You had to, I'm sure you were at the top of your class to be able to get into University of Chicago is a great school. And then obviously WashU.
Yeah. I mean, I think it was a combination of a lot of hard work, some smart choices, but a lot of people who opened doors for me. I'm very, lucky to have met a lot of people who opened doors for me along the way. And yeah, it's been a tough road, but here we are.
Yeah. Well, we're happy to have you here.
Thank you.
So some things recently in the news, Deion Sanders, of course, he's the coach of Colorado and, football player, baseball player, Neon Deion, recently was diagnosed with bladder cancer. And at least in the news reports, they said that they removed his bladder. And, most bladder cancers are early stage bladder cancers where they do TURBT, where they just go and scrape off the tumor from inside, and then that's it. But he must have had an advanced stage disease to have a removal of the bladder.
Yeah, I actually was able to listen to part of the press conference, and from what his doctor said, he had a non-muscle invasive but very high risk bladder cancer, which means it wasn't technically very advanced in such that it wasn't invading the muscle layer of the bladder, but it had some kind of histology or some kind of variant histology that made it a very high risk. And so that's why the decision was made to remove his bladder.
Yeah.
I have to assume. I don't know the details of it, of course, because that's protected patient information.
Sure.
But most bladder cancers, when they're diagnosed early, they're treated by resecting it in the operating room, and then some combination of either surveillance or putting some kind of agent into their bladder, whether that's chemotherapy or BCG, which we can talk about too. But yeah, in the setting of a more advanced bladder cancer, like invading into the muscle or other layers of the bladder, removal of the bladder is, the mainstay therapy.
Yeah. It's you can have these variants that are not like the typical transitional cell. I don't know if you can have a small cell of the bladder, but something like that, right?
Yeah, you can. There are other variants that are very aggressive, micropapillary being one of them, plasmacytoid being another one. And there are other criteria to determine whether or not a non-muscle invasive bladder cancer is very high risk. Part of it is the size of the tumor, if it's multiple locations, or if it has come back after resecting it.
Yeah.
So there are many criteria. So I assume he met one of those criteria to have his bladder removed up front for a non-muscle invasive disease. But
that's a big deal, and that's a tough. Life can be difficult after having the bladder removed. There was a guy I worked with named Randall Rowland, who pioneered the Indiana pouch when he was at Indiana.
Yeah.
And so super nice guy too. Super nice guy. But there's a couple different ways you can do a cystectomy as far as reconfiguring a new bladder, right?
Correct. Yeah. So when you do a bladder surgery or bladder removal surgery or cystectomy, generally speaking, let's talk about for males, because bladder cancer happens 4 times more often in males than females. You remove the prostate as well, the seminal vesicles and the bladder and some lymph nodes. And then once you do that, you have to reconstruct the urinary system so that you can plug the ureters in so the urine can drain from the kidney out somewhere. So there are several ways. One of them, the most common one, is called an ileal conduit, which means getting a piece of bowel and plugging the ureters into that piece of bowel and then bringing that bowel segment to the skin, and then the urine would drain continuously to a bag. Which can sound very life-altering, but it's also very well tolerated for patients. And there's a lot of resources for patients to see, to understand what life means after an ileal conduit. That's the most common one. The one that Deion Sanders got is called a neobladder. A neobladder is one where you use the same type of bowel, but instead of bringing it out to the skin, you reconstruct the bladder and you connect it to the urethra. There are several, indications for that. Not every patient is eligible for having a neobladder. They have to meet very strict criteria, and it can definitely be life-altering. He even mentioned that he's incontinent. That's very common after
he has
a
leakage.
neobladder. Yeah, he has some urinary leakage, which on daytime, it happens in about 20% of people, maybe 10, 20% of people. Nighttime incontinence is very common after a neobladder, up to 40, 50%. And then you have to be willing to, catheterize your neobladder. Bowel, as opposed to bladder tissue, makes a lot of mucus. So you have to be able to remove that as well, kind of mechanically remove it. So yeah, not everyone is eligible for a Deion Sanders neobladder, but yeah, that's another option. And then, as you mentioned, the Indiana pouch, which is literally creating a pouch out of bowel and then bringing either a piece of bowel or the appendix to the belly button and catheterizing through there.
Is that where you use the ileocecal valve to kind of help so it's not free flowing in?
Correct.
Okay.
Yeah, we call that the Mitrofanoff principle, where you bring the appendix up and you catheterize through the appendix. You basically make a tube out of the appendix and use as a channel to catheterize. And the channel is continent because of the ileocecal valve.
Okay.
Yeah.
Yeah, and then sometimes if patients aren't surgical candidates, we treat them with an intact bladder and treat it with chemo and radiation as well.
Absolutely.
And so there's several options if you have an advanced bladder cancer. But fortunately, most bladder cancers are early stage where you can keep your normal bladder and they just go in and kind of scrape away the tumor.
Correct. So the way I explain it to my patients is, the bladder has 3 layers, right? It has the bladder lining, then the muscle, and then the fat. We make the distinction in bladder cancer between muscle invasive and non-muscle invasive because in the muscle layer, we have the blood vessels. So once the bladder cancer reaches that layer, it can theoretically spread outside of the bladder.
Yeah.
And so for non-muscle invasive bladder cancer, so the ones that are either very superficial or just invade the first layer, you can treat by resecting, and sometimes you need to put chemotherapy or some kind of agent into their bladder through a catheter periodically. There are several protocols for that. And then when it comes to a muscle invasive bladder cancer, the standard of care is doing chemotherapy first, followed by a cystectomy.
Yeah.
And, the survival after something like that depends really on the stage of the disease, especially the stage at the time of the cystectomy. So once you remove the bladder and look at it under the microscope and see how much the tumor is invading into the bladder tissue, you can kind of get an estimate of, the life expectancy or 5-year overall survival, depending on how deep it goes into the tissue.
Gotcha.
If there's no tumor after the cystectomy, no tumor left, let's say it got treated by the resection and the neoadjuvant chemotherapy, survival at 5 years is somewhere between 85 and 90%.
Oh, that's pretty good for a muscle invasive. Yeah.
Yeah. And then once, you start going up, that number obviously goes down. And then for patients who are not candidates for this surgery, which is a big surgery, you get the trimodal therapy, which is what you alluded to, the resection plus the chemoradiation, which brings that 5-year survival down to maybe 65, 70%.
What's the most common presenting symptom for somebody who has bladder cancer?
Yeah, so the most common presenting symptom is hematuria or blood in the urine. All right, that can come in two forms. It can be microhematuria, where you have blood in your urine tests that your primary care or some other doctor does, or you can have gross hematuria that you can actually see it. Both are concerning. About 10% of people with microhematuria will have a diagnosis of bladder cancer. And when it comes to gross hematuria, that number goes up to 30 to 35%. So it's important to get tested, right? There are guidelines about this, especially for microhematuria. There are several criteria that you use to determine if the patient is low, intermediate, or high risk. And then depending on that, you do some kind of testing. But for the most part, and especially for gross hematuria, so blood that you can see, the testing for that is twofold, is a CT urogram, which is a CAT scan with IV contrast, where we not only look at your kidneys, but we also look at how your kidneys filter the contrast. So the contrast paints the ureter, which is the tube that brings the urine down to the bladder. And so we look at the kidneys, we look at whether or not there are kidney masses, or if there is a filling defect in your ureters concerning for a ureteral mass. We look at whether or not you have kidney stones. We look at the size of your prostate. And then the CT scan is not really good to look at bladder. So the second part of the testing is called a cystoscopy, which is a quick procedure we do in the office where we put a small camera through your urethra into your bladder, and we take a look directly at your bladder, right? A lot of people, they disregard blood in the urine for many reasons, whether because they had some kind of symptoms of infection or because they felt like they were dehydrated that day. But a lot of things can cause blood in the urine. It's not only bladder cancer, right? It can be a urinary tract infection. It can be stones. It can be an enlarged prostate in men over 50 years old. But definitely bladder cancer or any type of cancer of the urinary tract are the things that we're looking to rule out. So if you have microscopic blood in the urine, in your regular urine test, or you see any blood in the urine, you should consult a urologist, as soon as possible.
Yeah. And yeah, like you said, for those of you out there who kind of aren't familiar with it, the urinary system, it starts with the kidneys that filter the blood and then goes to the ureter, which is the tube that drains from the kidney to the bladder, and then the urethra, which goes from the bladder to either the orifice at the vagina or penis.
Yeah. And, even people with bladder cancer, up to 5% of them can develop disease in their ureters too.
Yeah.
And people with disease in their ureters, up to 30% 50% of those can develop disease in the bladder. So if you're ever diagnosed with either one, either bladder cancer or upper tract urothelial carcinoma, which is the cancer of the ureter, the other organ should be also surveilled.
You bet. And so what's the main risk factor for somebody developing like a bladder cancer?
The main risk
in America.
Yeah, the main risk factor is smoking or exposure to tobacco smoke, right? The thought being the chemicals that are in the tobacco smoke are filtered in the urine and are exposed in your bladder for a long period of time until you pee, and then over and over again, right? So all those amines are in your urine, affecting the DNA of the urothelium or the lining of the bladder, right? There are other risk factors, exposure to several chemicals used in textiles or concrete. There is some data about Agent Orange for veterans from Vietnam. There's even exposure to arsenic in Taiwan, for example, is a very common thing. Not very common, but it's one of the
known thing.
Kind
of like the aniline dyes.
Correct.
And so, but the thing that's kind of interesting is bladder cancer in America is different than bladder cancer worldwide. Here we have transitional cell carcinoma. And in other countries, you can have squamous cell carcinoma, which is thought to be due to, I think, is it schistosomiasis? Or?
Oh, yeah. So for the most part, bladder cancer is very similar in most countries.
Oh, okay.
But the one that comes from schistosomiasis is mainly in Africa. But yeah, for the most part, it's the same, although the variants are, a little different. But yeah, for the most part, it's urothelial carcinoma. That's the most common one.
Yeah.
But yeah, I mean, there is also, exposure to nuclear waste. That's a big factor. In fact, there was a law passed recently here in the U.S. Senate to give compensation to certain people in Missouri who lived in certain zip codes and have developed, some different types of cancer, including bladder cancer.
Okay. Yeah, that was the Coldwater Creek.
Correct.
Yeah. How about that?
So they're offering, I believe, up to $50,000 in compensation or to pay any out-of-pocket medical expense related to your cancer.
Yeah. Yeah.
We're actually giving out that information to our patients that come to the office with any kind of cancer that is on the list. So,
and this was very recently. I think it was Senator Josh Hawley who was the one who pushed it through.
Yeah,
or was he as a part of it?
I think it was a week or two ago. Yeah.
Yeah. And so it's horrible that it happened, but it's great that some of these patients are at least getting some compensation. Obviously, they would rather not have to deal with it, but at least,
of course,
they're trying to make amends to some degree.
Yeah, absolutely.
And then the other main cancer, you guys treat kidney cancer as well, but the other cancer that's the most common with men is prostate cancer. And recently, Ryan Sandberg, who was a famous baseball player for the Cubs, of course, we don't love the Cubs in this town, but we do love Ryan Sandberg, great guy all around. But he ended up having metastatic prostate cancer and died at the age of like 65, which is pretty young. I mean, of course you see it, but most prostate cancer, similar to bladder cancer, is a lower risk prostate cancer. Is that right?
Yeah. When it comes to prostate cancer, and nowadays, prostate cancer doesn't tend to be a lethal cancer in the sense that if it is caught early, there are a lot of options to treat it. Obviously, when it presents in someone that young, it is sometimes more aggressive. But prostate cancer, unlike bladder or pancreas or brain cancer, that are very aggressive, very rapidly progressing cancers. Prostate cancer is kind of a slow growing type of cancer for the most part. Obviously, there are exceptions.
Yeah. And so typically how it goes is somebody comes in, they get their screening PSA, and that's monitored every so often, usually starting at age 50, but there's controversy with that, like all screening. And then they have a bump in their PSA and they find that it's higher, and then they go and see somebody like you.
Yeah, absolutely. I mean, usually the best way to kind of get your foot in the door with a urologist is having an elevated PSA. PSA should be checked every year. you know, PSA in and of itself is kind of an imperfect test. Having it elevated doesn't mean you have prostate cancer. It just means that we have to investigate further. But it's a very important first step. And that's how we identify most, if not all, of our patients with prostate cancer.
Yeah, great screening tool. It's a blood draw, and then when somebody has an elevated PSA, usually you take them back and do a prostate biopsy. Is that right?
Doc Discussions with Dr. Jason Edwards, brought to you by St. Luke's, St. Louis.
Yeah, so because of the same reason that I was telling you earlier about being an imperfect test, back when we started using PSA, which the initial studies were done here at WashU, actually, by Dr. Catalona. When we started using PSA, we were biopsying everyone with an elevated PSA. And then we realized after a few years that we were overdiagnosing and over-treating patients, meaning we were doing a lot of unnecessary biopsies. So nowadays, we're a little more selective in whom we take for a biopsy. There are other tests that we can do beforehand. We can do biomarkers, which come in urine biomarkers or blood tests that are a little more specific. Then we have MRI of the prostate, which can tell us the size of the prostate and also if there are any lesions that are concerning for prostate cancer. And then if the suspicion is high enough for what we call a clinically significant prostate cancer, so one that can actually, limit your life expectancy, then we say, you know what, it's worthwhile going for a biopsy and see what you got, right?
Yeah. And then once patient, if they do have biopsy confirmed malignancy, you got a couple options there, right?
Correct.
And one of which is to do nothing.
Correct. Yeah. Prostate cancer comes in many flavors, right? You have the low risk prostate cancer where the most commonly accepted treatment or recommendation for it is active surveillance. So just keeping an eye on it, not forgetting about it, but doing, periodic biopsies and MRIs and, digital rectal exam, PSAs, just to keep tabs on it, make sure it doesn't progress. Then you have the intermediate risk prostate cancer, which kind of opens a couple more possibilities. There is, prostatectomy, which is what I do, and radiation, which is what you do, which both are equally effective to treat prostate cancer. The main difference is the side effects of each. And we both counsel our patients pretty strongly about those. And then there's high risk prostate cancer where, as long as it is localized to the prostate, the same options remain: prostatectomy and radiation therapy plus androgen deprivation therapy, which is basically giving injections to bring the testosterone down to less than 50, which is a very low level. And then there's the option of watchful waiting, which a lot of people don't talk about with their patients, but it's also important to do so because, like I said before, even the aggressive prostate cancers or the high risk, they're still, kind of a slower moving cancer. So watchful waiting is basically, not doing anything unless it becomes metastatic disease.
Yeah.
And some people prefer to do that to avoid the side effects of either treatment.
Yeah. And especially if you're, if a patient comes in and their wife's pushing them in the wheelchair and they don't look like they're going to live, maybe another 10 years. Of course, it's just an estimate. We don't know. But if their life expectancy isn't great, something like that may be a reason to do just watchful waiting.
Yeah, that's probably one of the hardest conversations I have in my clinic with my patients because obviously you don't want to tell anyone that they have a low life expectancy. But at the same time, the recommendations for PSA screening and for treatment of prostate cancer is based on life expectancy estimations in the US, right?
Yeah.
And so if a patient comes in with multiple medical issues that basically, means that they're going to have a life expectancy of less than 10 years, then you need to have that conversation as a urologist or as a radiation oncologist with the patients to tell them, look, you have to weigh the benefits and the risks of treatment to maybe be able to keep your quality of life as it is for the remaining years of your life. But someone has to have that conversation with those patients. So, it can become a little bit difficult. Yeah.
Yeah. I mean, the two metrics that we really care about in general with medicine are length of life and quality of life. And you don't want to just totally look at one and not the other. I think you need to, it's tough to kind of take it all into consideration and kind of make an aggregate decision about what's best for the patient. Of course, they help us. They'll we both listen to what they have to say as well.
Of course. And, urology specifically, which is obviously what I do, so I can talk a lot about it more, but urology is a lot about quality of life. We treat a lot of enlarged prostate, we treat a lot of erectile dysfunction, low testosterone, but the mainstay or basically the thing that we care about the most is how it bothers the patient, right? So if a patient has an enlarged prostate but has no urinary symptoms, we don't treat the number or the size of the prostate. We treat the symptoms of the patient.
Yeah.
Same for erectile dysfunction. Same for low testosterone. If a patient has low testosterone levels but they don't have any symptoms of hypogonadism, usually we don't treat it, right? So we focus a lot on quality of life. That's why we do the same with cancer treatment, despite being, cancer and not something benign.
Yeah. And so you mentioned low testosterone. Actually, a few episodes ago, we had Dr. Julie Gould on, and she's an OB-GYN, and she talked a lot about hormone replacement in females. Do you guys have a fair amount of patients who come in for low testosterone? Is that a common thing?
Yes, we do have a lot of patients that come in for low testosterone, both male and females. Yeah. Nowadays, it's, I think, more prevalent than it was before. There are reports of this, of how average testosterone levels have decreased in the general population. So yeah, we do see a lot of low testosterone and hypogonadism patients. And even in the setting of prostate cancer, in the right patient, I think it's a reasonable thing to do. Yeah.
And so what's the level have to be at typically before you treat somebody for low testosterone?
Yeah. So typically someone with low testosterone would be considered to have a level of less than 300 in 2 different draws.
Okay.
Usually we recommend testing testosterone before 10 a.m. That's when usually the levels are more accurate. And it's 2 different draws, assuming LH and prolactin levels are normal or they respond appropriately to the low testosterone. Then we go ahead and treat, assuming the patient has symptoms. Again, because you can have a testosterone of 200 and not have any symptoms, the benefit of treating you may not be there, right? But if you do have symptoms like low libido or fatigue or weight gain or erectile dysfunction, or even just low energy, then we go ahead and treat you if you have low levels. Yeah.
And do patients typically respond well to that?
Yeah. I mean, it's almost an immediate response. It's there are many ways of treating testosterone. There are injections in the muscle. There are gels that you can put on your skin. There's intranasal testosterone. There are subcutaneous injections. There are now pills for it too. And patients respond really well. I mean, it's kind of a life-changing treatment.
I see the inverse of that when our patients are on androgen blockers for treatment of their prostate cancer. And, they slowly have, not sometimes slowly, sometimes quickly, have more and more fatigue. And it's a challenge, to get out and exercise and maintain their strength and stamina and muscle loss and hot flashes and the whole bit. And usually when they come off of it, they feel great. Their quality of life, goes up significantly. And so what level are you shooting for when you give supplemental testosterone or androgens?
So we usually shoot for somewhere between 450 and 600.
Okay. And is the top like 800-ish or something like that? Like the top of the normal level?
Yeah. I mean, around 800, but people are different, right? But you don't want to overtreat with testosterone therapy either.
You bet.
But around the 450 to 600 level, people feel really good.
That's kind of a sweet spot there.
Yeah.
Very good. And then what are the risks of taking supplemental testosterone if you get your levels like 400 to 600? Are there any side effects from that or not really?
Well, it depends on the type of testosterone you're taking, but let's say, the typical injection, obviously injection site pain is one of them. There is, a theoretical risk of thromboembolism, right?
Okay.
So
Clotting.
Clotting. Yeah. So we check blood test, like we check a CBC to check the hematocrit every 6 months to make sure that the hematocrit levels are not too high. And if they are, we actually recommend patients to, donate blood to decrease that. So, but generally speaking, it's a very well tolerated drug. I mean, the risks of not treating testosterone deficiency are higher. You have cardiovascular risks, and obviously all the quality of life, effects that we just talked about.
Yeah, and you don't. As we get older, it pays to stay strong. You want to have good cardiovascular shape, but you want to stay strong too. And just getting weaker, say you're a little bit weaker, and then you get pneumonia, and you're in the hospital for a week, and then you really lose a ton of strength during that time because you're in bed, and then you lose it so quickly, and it takes a long time to build back up. And so you don't want to start off kind of a leg behind.
Yeah, and in the 80s, for example, when people were very hesitant to treat testosterone, the thought, or to treat testosterone deficiency, the thought being, if you give testosterone, you increase the risk of prostate cancer. And the reality is that, when you look at the patient holistically, you have, low testosterone is associated with obesity, metabolic syndrome, cardiovascular risks. So there are so many things that can get better if the patient just feels better from their testosterone, right? Let's say, you're fatigued because your testosterone is low, so you don't exercise. So you gain weight. So you become diabetic. So
you're depressed too. Psychological depression.
Yeah, exactly. And you have ED, then, your marriage doesn't work. And then, it's all these things that, make it so that when you treat testosterone, you can increase the patient's quality of life as well as their just overall health.
Yeah. And for whatever reason, I found that older men really that demographic seems to value quality of life, over length of life more than most other groups. It's just an observation. I'm not really sure why, but it's just something I've noticed over the years.
Yeah, I mean, I would agree with that. I would agree with that.
And so it's they take a really sensible approach to things typically, And so, do they know what's causing the lower testosterone? I'm sure there's some hypotheses out there, but is it something in the environment or?
It could be environmental exposures. I mean, some people who take testosterone replacement for, let's say, exercising in the past, that can have some effect in their pituitary, axis and all of that. So that could be one of the reasons. Environmental factors, definitely a reason,
Yeah, I know the bisphenol A was a big deal. And so now when you get an Nalgene bottle or whatever, it'll say BPA free on it. And so that was something, it was actually a guy from the University of Missouri who was all over that, but they found that these microplastics were causing, I think they were able to show in fish that they were able to get them to like switch, like physical sex.
Wow.
But I could be wrong on this, but I think that's what it was. But it was also hypothesized to cause lower testosterone. And so get your water filter.
Get your Brita.
Yeah. Well, Nimrod, we're so happy to have you here on campus. It's a pleasure to work with you. All your patients love you. You're a big hit.
Oh, thank you.
And if people want to get a hold of you, the number at the office is 636-685-7830.
Perfect. Yeah. We're at the DOC building, second floor, suite 24B.
Perfect. Thanks, Nimrod.
Yeah. Thank you. Thanks for having me.
Join us next time for Doc Discussions with Dr. Jason Edwards. It's medicine for your body, mind, and spirit.